I was just waiting for all the friends to join. We'll start the class because whoever has come should benefit from the class rather than waiting for the class. So we'll move to the next session after looking into the importance of ST elevation, ST depression, and T wave. We'll look into the next of bundle branch block. So before going into the bundle branch block, we'll look into the physiology of conduction, how it conducts, why it is rapidly conducting, why QRS is narrow. Then we'll look into the bundle branch block. See here, the conduction happens. This is the first thing which we saw in the first class. The conduction happens from the SA node. From the SA node, it reaches the AV node. See it from the AV node. From this, it conducts through the specialized conduction system, that is bundle of his right bundle branch, left bundle branch, which divides into two and reaches the Purkinje fibers. Since the conduction is so fast in this area, it conducts to all the Purkinje fibers almost at the same time, so that the whole ventricle, either it is left ventricle or right ventricle, contracts in unison and cardiac output is affected. So you have to understand the stroke volume, what you are going to give is going to supply the whole part of the body. For that, the small heart, only a fist-sized heart, has to pump blood. So it means that it has to effectively pump blood. And for that, to effectively pumping blood, this conduction system is the most important part. Below the AV node, the conduction system, bundle of this, right bundle and left bundle, has to conduct very fast so that whole ventricle are innervated at the same time. This is what happens. So the normal conduction speed in the ventricle conduction system is about 0.1 seconds. See here, it is about 0.1 seconds. And this is the reason for the normal narrow QRS in the ECG. So the QRS should be less than, most of the time, less than 2 small squares. Already I told you, the P wave is also less than, almost nearly less than 2 small squares. And QRS is also less than 2 small squares. So less than 2 small squares. This is because the conduction system is conducting so fast that the bundle of his to the up to the Purkinje fiber takes only 0.1 second to reach, so that the conduction happens very fast. So because of this, and from there you have to understand the first part of the ventricle, because left ventricle is the dominant ventricle, the first part of the ventricle will be conducted, left ventricle. The conduction happens from this first part. See here, from this first part, because it is the left dominant ventricle, the first conduction happens in this area, right? From there on, it conducts to the left bundle and right bundle. So that is the reason in V1, there will be a small R wave. In V5, V6, there will be a small Q wave. I'm just sorry that my computer is struggling and it's not moving. So this is how it happens, where the first part of the ventricle to be stimulated is the left side of the ventricle septum. So left-right conduction is the normal first part. And clearly, there will be two conduction abnormality, bundle branch block. One is the right bundle branch block and another is the left bundle branch block. We will start with the right bundle branch block. See here, the first conduction happens between left to right. Here the right bundle is coming like this from the right side and the left bundle is coming like this. Because the left bundle is conducting properly, the first conduction will always happen. See here, the first conduction, right bundle is blocked here. Right bundle is blocked here. Right bundle is blocked here. See here, right bundle is blocked here. So the left bundle is conducting here. From the first conduction from the left to right happens. So what will happen in V1? V1 is, as I already told you, V1 is like here. V1 is like here. So from left to right, first conduction happens. So towards the electrode, it is always positive. So in V1, it is always positive. First, the initial R wave is always present. Then the conduction happens from this area towards this apex. So this will be from V1, we are looking from V1, the apex, towards the apex is conducting. So away from the V1, it is conducting means there is going to be a negative wave. So this negative wave is, see here in the bottom of the figure, there is a S wave. After the initial R wave, there is a S wave which is happening. And from there on, see here the third part of the conduction, because right bundle is not conducting, the conduction from the left ventricle through the muscle junction, it conducts to the right ventricle. See here, the third part is conducting like this. When it is normally conducting, both the ventricles are simultaneously innervated and both the ventricles are conducting in unison. Here, after the left ventricle is conducting, conduction happens, the right ventricle conduction is happening. So there is here V1 is here. So towards V1, again the electrical impulse comes and it takes a longer time because it is not conducting through the conduction system. It is conducting through the adjacent muscle. So the next R wave will be taller. See here in the bottom, taller. Because the QRS is wide, last class I told you, whenever there is going to be a QRS wide or the height of R is very tall, you will always have secondary repolarization abnormality. So ST segment and T wave inversion happens. See now, there is a RSR pattern in right bundle branch. Why it happens? Because the first conduction is always present because it is the left bundle which is conducting. The left bundle, left to right, first conduction happened, causing a positive VR wave. The second conduction is towards the left ventricular apex, which is away from the electrode, causing the S wave. Then the third conduction is conducting from muscle to muscle, adjacent muscle. That is takes a longer time. So there is a tall R wave. See now, RSR pattern in V1. The same thing opposite happens in V6. So there is a terminal negativity, S wave in V6, and there will be a initial negative Q wave in V6. Now you understand, very simple. RS, if you happen to see a small R, S, and a tall R in V1, you are dealing with right bundle branch block. As simple as that. Sorry, again, whenever I annotate and draw a picture, the system is not moving. I'll just make arrangement. So the right bundle branch impulses travel through the myocardium of left ventricle to the right ventricle and depolarize the right ventricle, not by the conduction system, but by the adjacent myocardium, so that the QRS complex is wider. You call the terminal delay, it is not the initial delay, so that the QRS complex is wide. There is in the V1, you see a tall R wave. So RSR pattern. So the more diagrammatic picture of what we are seeing. See here, it is the SA node, AV node. From the AV node, the right bundle branch is blocked. Right bundle is not conducting. The left ventricle, the purple color is the one which is conducting. After conduction, see here the arrow. After the left ventricle is conducting, the arrow conducts through the muscle and innervates the right ventricle, so that there is a initial small R wave, deep S wave, and a tall R wave. Terminal delay is there. So the criteria for right bundle branch will be like this. QRS is more than 3 small squares. You have to understand more than 3 small, 120 milliseconds. You have got a terminal wide S wave in V1 AVL V5 V6. That is called the terminal S wave in V5 V6, which is a characteristic of right bundle branch block. Small r, S, and capital R dash pattern in notch wave in V1. So typical. This is what the rabbit ear, whatever you want to call. RS R dash pattern in V1. QRS is wide S1 in lead 1, and terminal S in V5, V6. And always there is going to be a secondary STT changes. We call it as discordant STT changes because the depolarization wave is very, very wide. It takes a longer time for the ventricle to contact, so that the depolarization is always happening opposite to the QRS complex, right? So that is the reason why there will be a second. See here in V5, in lead 1 and V5, V6, this will be there. There will be a terminal negativity, deep S wave will be there in V5, V6. Typical RSR pattern in V1. See here, there is a small r followed by a S and a tall R, which is delayed. So terminal delay, RSR pattern, M pattern, or a rabbit ear pattern, right? So why it is very important? See, normally normal variant also it can happen. Sometimes in characteristically in ASD it will be there, pulmonary embolism can be there, right axe deviation will be there. Lot of occasion there will be a right bundle branch block. But I am frightened to see only one thing. See here in anterior LMI with the right bundle branch block means it suggests that the first perforator of the LAD is occluded. It means the proximal LAD occlusion is there. So whenever there is going to be a proximal LAD occlusion, so you are going to have a large myocardium is at risk and patient can die anytime. So this requires this ECG. On looking into this ECG, there is a Q wave suggesting an anterior LMI, which is getting evolved, and it is myocardial infarction is happening. And there is a ST elevation. It means that ongoing ischemia infarction is happening. And on top of it, there is a right bundle branch block pattern is there. So this pattern with the terminal right with the ST elevation always suggests that QRBB, what we call as a QRBB, this is called the anterior LMI with right bundle branch block. The site is alarming because the patient has got a very, very poor prognosis. RBB most of the time produces only secondary STT changes because of the wide QRS, which causes secondary repolarization abnormality following a abnormal depolarization. Sir, RBB can be present normally also. It is unlike LBBB where we need not suspect acute MI just on seeing an RBB. In pulmonary embolism, ASD, COPD with pulmonary hypertension, valvular PS, chronic degenerative changes in the system, and rarely coronary disease, but it is a very terrible disease to have once you have an RBBB. So V1 or V2 will have RSR, that is M pattern or rabbit ear pattern. So the right bundle branch will have rabbit ear or M pattern in V1, V2. So you need not panic. This is not abnormal unless you have a ST elevation, primary STT changes, or Q wave. So V5, V6 will have a small Q, septal Q will be preserved, and a R and a terminal negativity called the terminal S will be there. So the large R wave is due to the second depolarization happening in the right ventricle after the left ventricle, and there will be secondary STT changes following it. So the QRS width will be most of the time more than 120 milliseconds or 3 small squares. More than 2.5 small squares, we call it as incomplete RBBB. See here, this is a typical LBB RBBB pattern. The V1 is showing, you are seeing the V1 is showing RSR dash pattern, and you are having a terminal S in V6. So this is what will happen. Our terminal S in V1, lead 1, lead AVL, V6, V5 will be there, and a RSR dash pattern in V1 and the QRS complex wide. This suggests the patient is having RBBB. So now you understand right bundle branch block. We will move to the left bundle branch block. So left bundle branch block, what I told you, the first conduction should be from the left ventricle septum towards the right ventricle septum. But what happens here, the left bundle is blocked. So it means that the right bundle is only conducting. After the right ventricular innervation, the left bundle has to innervate. So the first conduction cannot happen from left to right. So when it is not happening from left to right means the initial small R wave in V1 and the septal Q in V5, V6 is lost. So you have to see and understand the first loss of septal R wave. The first initial septal, which is normally present in every individual, will be lost in left bundle branch block. So you have to understand left bundle branch block. Loss of septal R wave is not there, or a septal Q in V5, V6 is not there because left bundle is branch is not the first conducting system. Right bundle is the first conducting system. The first innervation happens from the right to left. So there is going to be a V1, there is going to be a absence of R wave, loss of septal R wave in V1 and septal Q in V6. That because it is not conducting through the conduction system, QRS complex wide, usually more than 120 to 140 milliseconds. It is more than 3 or 3.5 small squares. The QRS complex, because it is conducting V1 is here, all the QRS complex innervation happening from right to left. So all the QRS complex will be negative. So V1 will, V6 will always show positive QRS complex. Now you understand why it is negative in V1, why it is positive in V1. So because it is right to left bundle is left bundle is blocked. Right bundle is the only conducting system. First, the right ventricle is innervated. The first conduction doesn't happen from left to right. So loss of R wave in V1 or septal Q in V5, V6. And the second conduction is happening completely in the right ventricle. And from there on, it moves towards the left ventricle and conduction happens. So there is a loss of R wave will be there. And the initial the negativity will be there completely because the complete conduction happened from the right to left. The whole ventricle is conducting. So there is a loss of septal Q wave. V5, V6 will not show septal Q wave. And there will be a tall, positive, wide QRS complex in V5, V6. So activation of the left ventricle is delayed and contract later than the right ventricle because of the left bundle branch block. QRS duration is more than 120 milliseconds. Broad R wave in lead 1, ABL, V5, V6, always positive in V5, V6. Whereas you saw in right bundle, it was terminal negativity. Here it is always fully positive. Predominant QS in V1, absence of septal Q in lead 1 and V6. So you understand why it is not happening because right bundle is the only one conducting. Left bundle is not conducting means there is the initial left to right conduction is not happening. But is not happening towards V1 means there is an absence of septal Q wave or in V5, V6 or an initial R wave in V1. Now you can see here in V1, hardly any positivity. It is almost complete negativity. In V5, V6, you are seeing a completely positive QRS complex. See here in lead 1 and ABL, completely positive, wide QRS complex, more than 120 milliseconds, completely positive, whereas it is completely negative in V1. So broad R in lead 1 and ABL, prominent QS is in V1, absence of Q in lead 1 and V6 septal Q, and secondary STT changes, which is happening because of the wide QRS complex and delayed depolarization. Now you understand why it is simple LBVB. So wide QRS complex, V1, it is predominantly QS. R may have W shape in it because it is very wide. V6, R are notched R showing a M pattern like this, and it is wide, always fully positive. Secondary STT changes happens because of the depolarization, wide depolarization, and at secondary abnormal repolarization. See here in QRS complex with it is wide and LBBB lead 1 ABL is showing fully positivity. V6 is showing V5 is fully positivity. Absence of septal Q wave, almost like a QS complex in V1, V2. There is nothing, initial R wave is not present. This suggests that the patient has got a complete left bundle branch block. Now, how to differentiate between these two? Normally, V1, there is a septal Q wave, so initial R wave, and a septal Q wave in V5, V6, and initial R wave. Whereas in RBBB, because the right bundle is blocked, there what will happen? You are seeing a for initial R wave, left to right conduction. From there on, the right bundle is blocked, so that there is a right side conduction is not happening. The left ventricle is conduction is picked up by this term mid S, and you are seeing a tall R S R dash pattern, tall R wave, because the left right conduction occurs from the muscle to muscle. Whereas in case of left bundle branch, in V5, V6 in left bundle branch block, the initial Q wave which was there will be completely absent, and you will have a tall R wave in V5, V6, and a terminal QS pattern in V1. Whereas in right bundle branch block, you will be having a terminal negativity. In left bundle branch block, complete positivity. Now you can understand that this is right bundle branch block V1 and V6. This is left bundle branch block in V1 and V6. So moving on from the gross conduction block, that is right bundle and left bundle is blocked. You know that it is simple. M pattern, when you see M pattern in V5, V6, it is left bundle branch block. RSR pattern in V1, it is right bundle branch. As simple as that. You are most of the time RBBBs are innocent, but when you see a Q wave ST elevation with RBBB, you have to panic and you have to urgently act, because patient will have a proximal LAD occlusion and will enter with arterial MI, which will be life-threatening unless it is intervened very quickly. Moving on to the branches of the conduction system, fascicular blocks. So it means that the left bundle is dividing into two fascicles. See here, left bundle is dividing into two fascicles, left anterior fascicle LAF and the left posterior fascicle. So left posterior fascicle, if you happen to see, is wide, it is slightly deeper, and it is supplied by two arteries. So it is not easily damaged by any ischemia. Whereas see here, this left anterior fascicle is narrow, thin, and it is so slightly superficial, and it can be affected by any, whereas it is having only single arterial supply, and it can be affected by ischemia very, very quickly. So that you have to understand, left anterior fascicle is the common type, and left posterior fascicle is diagnosis by exclusion. It is not a common diagnosis. So left anterior fascicle and left posterior fascicle. Because left anterior fascicle and left posterior is a subdivision of it, the other two conduction system is conducting rapidly. The QRS is not going to be wide, because two conduction system, right bundle and the left posterior fascicle is conducting. Only left anterior fascicle is affected, means conduction is happening, but it is not very wide, because only this area will conduct slowly. Rest of the area, there is a proper conduction system which will conduct very rapidly. So the QRS is not as wide as left bundle branch block. It is slightly narrow. It means it is narrow, less than 120 milliseconds only, 100 to 120 milliseconds. Now you understand another point, carry the message, less than 120 milliseconds in fascicular block. In fascicular block, the duration of the QRS complex less than 120 milliseconds, because for the only reason, two systems are conducting properly. The only one small system is not conducting, so that the conduction from the muscle to muscle is happening in a small area. So the QRS complex slightly narrow. Here, the characteristic hallmark of left anterior fascicle is left axis deviation. It is more than minus 30 degree. So straight away, it means that lead to 3 AVF will have RS complex. QR morphology in lead 1 and AVL, RS morphology in lead 2, 3 AVF. Now you understand why it is happening, because the axis going towards the left, it will happen like this. See here, RS pattern in, it is not inferior wall MI. See here, there is a small R, S pattern in 3 AVF. It is not inferior wall MI. And a QR pattern in lead 1 and AVF. Typical of left anterior fascicular block. Left axis deviation, QRS is slightly wider. It is not very wide like a left bundle branch block. QRS is less than 100 to 120 milliseconds. RS pattern in lead 2, 3 AVF. Then you are thinking about left anterior fascicular block. Left anterior fascicular block, initial QRS forces are directed rightward. So negative in because it is anterior is blocked. So it goes to the right and posterior. So initial QRS forces are directed rightward, negative in lead one. See here, negative in lead one, and inferiorly, so that the positive in leads, okay, initial positive in lead 2 and 3. Subsequently, all the forces are directed leftward. That is the reason why left axis is there, and superiorly, so that you are having a RS pattern. If you are confused with the direction of the force of vector of current, make it very simple. RS complex in 2,3 AVF, small r and deep S complex in 2,3 AVF suggests there is an extreme left axis. The QRSS complex is more than 100 millisecond, but less than 120 millisecond. It means that you are dealing with left anterior fascicular block. Left posterior fascicular block is diagnosis by exclusion. Do not diagnose. Very, 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 very rarely you are diagnosed, so that it is not a diagnosis to be mentioned at all. But only thing, it is exactly opposite of what is happening left anterior fascicular block. You are seeing a QR in V lead to 3 AVF and RS in lead 1. It's exactly opposite to that. But you will not come across this. So forget about it. You don't really need to look into it because it's very, very rare and it's not going to happen. It is diagnosed exclusion because the left posterior fascicle is thicker, more deeper, less affected by ischemia, less affected by degenerative changes. So and it's not very common. So that it is not a common diagnosis. Forget about it. So moving on to the next conduction block, bifascicular or trifascicular. Now you know there is conduction is happening. One right bundle is one fascicle, left bundle is divided into two fascicle, anterior and left posterior fascicle. So now you can see when you have right bundle plus left anterior fascicular block, you call it as bifascicular. If it is right bundle branch and left hand fascicle is blocked, and AV node is also blocked, it means that there is going to be a conduction abnormality, slowing conduction in the third fascicle also. If it completely occludes, means it is complete heart block. When it is conducted with a delay, then we call it as trifascicular block. Now you understand? Bifascicular, one fascicle is always right bundle. The other fascicle affected is, if it is the anterior fascicle, then you call it as RBB with LAFB, and this causes white causes the left axis deviation, and the left posterior fascicle block, already right bundle branch block is there. Extreme right axis you need to call it, but it is rare. Bifascicular blocks are potentially significant. Why? Because during acute MI is a warning sign that it is patient is going to a complete heart block very quickly. Now see the bifascicular block. See here, there is a, if you happen to see right bundle branch block. Right bundle branch, RSR in V1. Terminal S in V6. Now you white QRS complex, more than 3 small squares. Secondary STT changes, typical right bundle branch block. Now, if there is going to be right bundle branch block, you expect the axis towards the right. Right side means 3 AVF, because it is right side means the AVF should be positive. See here, AVF is negative. So when it is AVF, 2, 3 AVF is having a negativity, predominantly an RS pattern, you call it as right bundle branch block with a LAFB. So with two blocks, right bundle and one fascicle is blocked, we call it as bifascicular block. Now understand why it is called as bifascicular block. So when this happens, and if we have a AV nodal delay, you call it as trifascicular block. That's all. PR interval prolongation, right bundle branch block, and a LAFB, all three put together, you call it as trifascicular block. It is just a step before patient going into complete heart block. So this has to be viewed more seriously than bifascicular block. In acute MI with a bifascicular block, patient is possibly going into impending complete heart block, and we need to treat them urgently. So the summary of whatever I told, right bundle branch block is most of the time benign. Sometimes it can be happening, especially in anterior MI when it is happened. You have to treat it very, very quickly because it is a life-threatening situation. Right bundle branch block, here you have the ECG, right bundle R, S, R dash pattern, small r, deep S, and a tall R in V1, and a terminal negativity in V6. QRS complex is wide, more than 120 millisecond, you call it as right bundle branch block. When you have a left bundle branch block, you are having in V1, there is loss of septal R wave, and in V5, V6, loss of septal Q wave. So it means that predominantly negative QRS complex with a wide QRS complex in V1, W pattern in V1, or a M pattern in V5, V6, we call it as left bundle branch block. QRS complex is more 120 to more than 120, 140 millisecond, and you have lead 1 and AVL will show wide QRS upright QRS complex like a M pattern, like a similar to V5, V6 will be there. In case of bifascicular block, one fascicle is always right bundle, the other fascicle is left anterior posterior fascicle, posterior fascicle is rare. So we always see right bundle branch block with a bifascicular left anterior fascicle block. What we see in the ECG, it is a rare pattern recognition. You can always see right bundle branch block. You are expecting a right axis deviation. When it is not happening, that means that you are dealing with RS complex. You are dealing with the posterior fascicle. Left hand, the LAFB is also happening along with the right bundle branch block. So right bundle branch block with the left axis deviation will happen. The same ECG with a prolonged QRS count, where PR interval means you are calling it as trifascicular block. It means that it is an advanced conduction abnormality. So impending complete heart block is there. So patient is likely to go into complete heart block very quickly. We have to intervene very properly. Thank you for your patient hearing. I will unmute all. You can always have your diagnose. You can unmute yourself and ask questions if any, or put it in the chat box so that I'll answer your queries. Any queries you have?
Sir, one question.
Please, sir.
The patient is stable. Only the RBB is the seen in ECG. We have to take it seriously, or it is a benign type. What is your opinion,
sir? Our right bundle branch block can be benign in whatever we are seeing it. When there is wide QRS complex, RSR pattern, R' pattern in V1, that is a rabbit ear, whatever you can call, and a terminal negative wide QRS complex, S wave and wide QRS complex in V5, V6 means you are dealing with right bundle branch block. Most of the time, right bundle is very, very superficial bundle, so that because the right in the pediatric age group, during embryonic and pediatric age group, right ventricle is equally dominant. So this can cause ischemia or some compression in the right bundle, and when we create normal presence. So it means normal variant is the most common type of right bundle branch block. You need not treat right bundle branch block unless there is no symptom or anything. You need not treat. But it can show you that there could be an underlying disease. What is the underlying disease? Whenever there is going to be right bundle branch block pattern, you have to rule out straight away congenital heart disease. ASD should be ruled out. Pulmonary stenosis should be ruled out. Two things. So if two things are ruled out, you are safe. Rest all is normal. When do you want to suspect it a right bundle branch block and you view it seriously? When there is a Q wave, instead of a initial positivity, there is a Q wave and a ST elevation in V1 to V4 means you are dealing with a anterior wall MI. That is the point where you have to view it seriously. Otherwise, it is a normal variant. Nothing will happen.
Okay, thank you, sir. if the same LVB with tachycardia, if the heart rate is more than 100, is there any change will come in RBB pattern? If it is tachycardia with RBB.
Sir, there is whenever there is going to be a conduction system abnormality, see, it is like graying of hair, as simple as that. As you get older, there is graying of hair, like every system is getting degenerated. Likewise, your conduction system can also get degenerated. When it is getting degenerated, normal conducting at a normal speed, the conduction system function properly. When it is conducting at a faster rate, so at that point of time, it is not able to conduct normally. So it conducts slowly. When it conducts slowly, you have bundle branch block. As simple as that. So there will be a rate dependent. In 70 heart rate, you can have normal conduction. 100, 110 heart rate, you can have either left bundle branch block or right bundle branch. Common is right bundle branch block. So whenever there is going to be a abnormal degeneration, it always indicates there is a degeneration is happening. In future, it may happen at a heart rate of 60 or 70 also. So this is the indication that it may happen later on. So this is going to be, most of the time, it is all again benign at that point of time. When it is happening normally less than 100 and it is conducting with a wide QRS complex, that is either right bundle or left bundle, you need not panic. So it is only a rate, some sort of a degeneration happening and a rate dependent bundle branch block is happening. But what we have to differentiate is rate dependent ventricular tachycardia. So when there is initial P wave is preceding the QRS complex, we are happy that nothing is going there. P wave preceding a QRS complex, that means that is sinus tachycardia, QRS complex wide, rate dependent bundle branch block. Whereas QRS not there, wide QRS, it is rate dependent ventricular tachycardia. So every time you have to look into the P wave, which should precede the QRS complex before deciding on it.
Okay, thank you, sir. Thank you.
Is there any other question?
Sir, is there any category of the Purkinje block? Is there any category? At the end or terminal of the conducting system, Purkinje fibers block, Purkinje block, is there or not, sir?
Sir, we need not worry about it, sir. That we can identify only with the electrophysiological study. We cannot identify with any of the ECG. In a signal average ECG can pick up some subtle changes which is happening in the terminal part of the QRS complex, which we can pick up in the signal average ECG. This is a refined form of ECG, which pick up the micro current which is happening within the car. So in 12 lead ECG, we can never see a Purkinje fiber abnormality.
Because sometimes we are seeing the QRS, the downslope is a bizarre type. Some
that is intraventricular conduction. That is intraventricular conduction abnormality. So there can be a localized scar area, or there can be a conduction abnormality. A muscle is damaged, possibly related to a old infarct,
post-infarction,
post-infarct, or a previous myocarditis, or something like that. That point, patient, there will be a conduction abnormality with the area of necrosis. There will be totally no conduction happening. So that will give you a bizarre QRS complex, multiple subtle QRS complex, slurring in the QRS terminal complex will be there, which is called a peri-infarction conduction defect or a intraventricular conduction defect, which is normal after a post-MI in a localized scar.
Okay. So there is no special treatment for that changes.
That patient can have a ventricular tachycardia, sir. So these patients are more prone for ventricular tachycardia because necrosis is there and adjacent normal myocardium will be there. There will be a electrical difference between these two, and there is patients are prone for ventricular tachycardia. So we have to assess.
The patient may need of antiarrhythmic. May need of antiarrhythmic
and decide on it.
Precautionarily.
Sir, antiarrhythmics are all potentially arrhythmogenic as well as with huge side effect, comes with a huge side effect. So we should not unnecessarily give antiarrhythmic except beta blockers. So only beta blocker is the one which we need to give, and amiodarone is the one which can be prescribed, but it requires lot of attention, holter monitoring, analysis of the ECG and everything before starting amiodarone, because it is a potentially side effect from head to foot. All system can be involved.
Including thyroid also.
Thyroid, head to foot, sir. From skin to foot, every system will be involved in amiodarone as a side effect. So we should not prescribe amiodarone just like that, just seeing something abnormal. It's always beta blocker is the arrhythmic drug for most situations.
Thank you, sir. Thank you. Very good point, sir.
Thank you, sir.
Thanks, madam. Thank you, madam. If no questions,
Excuse me, sir. Sir, in left bundle branch block, like if we are first time taking an ECG and we find that there is a left bundle branch block, we don't know
tell
whether
me.
it was existing earlier or not. So what do we do with that, sir? Do we further evaluate that, sir, without if the patient doesn't have any symptoms?
Right, very good question. Whenever there is going to be left bundle branch block, you by whether it is innocent or it is a problematic. That's the one question. When the patient comes with this chest pain, the previous class I told you Scarbosa criteria. So Scarbosa criteria should be applied. So when there is going to be a V1, there is a fully complete negativity. White QRS means there is to be a secondary STT changes, which means that water QRS negative means STT should happen opposite to that. It should be positive. That is normal. When it is more than 5 millimeter positivity in V1, V2, more than ST elevation, more than 5 millimeter, then it is your problem. It means acute MI is happening. Or in V5, V6, you are having only positive pattern, M pattern. Here, there should be a terminal negativity. That means that STT change should be opposite to it. If it is not there, M pattern and the T is also upright. That means that is here again M, primary STT change we call, and here also this LBB should be viewed significant. In V1, V2, if there is a W pattern, instead of going upright STT, you are seeing an inverted T wave means again you are dealing with a acute MI or acute coronary syndrome. So in LBBB, when you see the same side, synchronous, same side, it is concordant with the QRS complex. It should all STT should always be discordant with the QRS complex. Same side as the QRS complex, it means you are dealing with an acute MI. If the ST elevation is more than 5 millimeter in V1, V6, then you are dealing with an acute MI. So LBB with these changes, you should always view it seriously and we have to immediately take action. But when you happen to see a asymptomatic individual with the LBBB, most of the time is normal. It could be a normal variant which has been present throughout their lifetime. So here, how do you differentiate? Asymptomatic, do an elective echo and see no RWMA, normal, ask them to record the ECG, have the Xerox of it, so that every time they come, they need not get panicked about it, and the doctor also need not get panicked. So we can happily leave them alone. But I told you the Scarbosa criteria, when it is present, then you have to view it very seriously and treat the patient in an emergency way.
Thank you, sir. Very good.
About trifascicular block, sir. Sir, in trifascicular block, as a periphery medical officer sitting in periphery, what do we need to do, sir?
A trifascicular block, usually in an inferior wall MI or in an anterior wall MI means it's a sign of the patient going for a complete heart block. When a normal person, say 70-year-old, comes with a right bundle branch block and a LAFB and a first degree AV block. So what if the patient comes to me, what I will do is I'll just make the patient lie, connect to the hemodynamic monitor, and then start asking the patient to flex their limbs or clench their fist, something like that, and increase the heart rate. Whenever I increase the heart rate by simple maneuvers, I'll just record the ECG and see. The patient will go into complete heart block if there is a vulnerability. So increase the heart rate, patient go into complete heart block. That means straight away we can say the patient has got severe conduction system abnormality and goes for a. But this I do it in a controlled situation and everything is available for me. But in a peripheral scenario where you are seeing a right bundle branch block, LAAB, first degree A block, send the patient to the cardiologist for evaluation for conduction abnormality, and most of the patient will need a permanent pacemaker implantation.
Thank you, sir.
Right, if no more questions, I think we can wind up. Thank you very much. Thank you. We'll wind up. Thank you.